coming. I know it's really early. So this is our second monthly Breakfast at SSCY session, and I'm really happy to have Dr. Anna Hanlon-Dearman from the Child Development Clinic and the Manitoba FASD Centre here to present about sleep in children with neurodevelopmental disabilities. So the Breakfast at SSCY sessions are the second Tuesday of every month, and they'll be on a range of topics that may or may not, hopefully may, be of interest to SSCY Centre families and staff and just other therapists around and just anyone interested. So we also have it available as a webinar. And then the recordings of the session will also be available on the SSCY website if people wanted to view them after, or if you are talking about what an interesting presentation you saw to someone else and they wanted to watch it, direct them to our website and then they can watch it as well. So I'll pass it on to Anna, and then there'll be time for questions at the end. So for the people who are watching as a webinar, if you want to type in any questions or comments you have, and then I would read them out at the end to Anna and she can answer them.
Thanks, Jessie. Well, I'm very pleased to be here to talk, I guess, for the first webinar of the year. So thanks very much for having me. Today's presentation, I'm really just going to focus very much in a general sense on some of the sleep difficulties that one can see and special considerations for kids with different neurodevelopmental disabilities. I'm going to briefly overview some considerations in assessment and treatment, and I'm really going to think about how we integrate that and then just spend a very, very brief slide on a new research project that'll be coming out soon that you may hear about, just so that you're aware of it, and which is specific to kids with sleep and neurodevelopmental disabilities. So a very typical consult that I get says something like, please see this child with whichever neurodevelopmental disability they may have and poor sleep, and mom is exhausted. And so what I did was I put together some composite considerations that I might see in a case that could really apply to almost any of the consults that I generally get. And so for this particular case, Jordan is a 6-year-old boy. He's referred with very common problems of sleep, of difficulty with night wakenings and difficulty falling asleep. And he's been a restless sleeper since birth, since day one. The birth history is a little bit unremarkable. It's a young mom, first-time mom. He was a little bit jittery and disorganized at the beginning, but medically, his review of systems is pretty unremarkable. Mom is single. She's a student. She works evenings at night. She lives in a side-by-side in Manitoba housing. She gets some casual after-school daycare. He sees his dad irregularly on the weekends. They have different schedules at places. Parents don't communicate all that much. He's supposed to go to bed at 8, but he often stays up till around 10 when his mom comes home from work. He's often falling asleep on the couch or in a chair, pretty much wherever, and often falling asleep in front of the TV because that calms him, and then mom brings him to his room later. At night, he's often waking screaming. His mom isn't too sure whether he's always awake during that time or not. He's often rocking, he's sometimes head banging, and she sometimes just allows him, well, more than sometimes, to sleep with her because she's afraid the neighbors from the side-by-side are going to call CFS on her, and he's tired and dysregulated during the day. So that's very common kinds of concerns that I generally see. So I often have to consider in broad a whole bunch of different things there, as you can imagine. And what I'm going to do is talk about briefly first why kids need to have a good night's sleep. And this could be a presentation all by itself. And then I'm going to talk about some specific areas. So in general, sleep affects everything. It affects how we think. It affects our memory and attention. It affects our motor skills. It actually has quite a significant impact on our immune health. It can contribute to obesity. It can contribute to mood and behavior in all kinds of different ways besides just being tired, but also ways that we don't think about. Little kids often look hyperactive when in fact they're tired. It can contribute to anxiety, depression, mood disorders, and it can also have a significant impact, as maybe we all know as adults, on our own ability to manage stress. It can for sure affect performance at work and school and contribute to an increased number of accidents. The National Sleep Foundation in the States has a nice chart that they've recently updated. So you can find this on their website that's at the bottom there. That really gives you an idea of, in the dark blue, how much number of hours kids should get, and right through to adulthood, on average, but it gives you in the lighter blue kind of the bracketing range. So you could even see, for example, that a newborn, if you started on your far left there, could get as little as 11 hours of sleep per 24-hour period, which I think most of us would feel like is very little, but could more typically get a higher number of hours, 17, 18 hours of sleep per day. And then you can see how that decreases. But the other things to consider when we look at sleep over the age span is at the top, and this is also from an Australian website, on the top, the patterns of sleep we get. So it's focusing more on babies, where you can see kind of the consolidated sleep at night, but periods of napping during the day. And you can see how those daytime naps kind of funnel down into about 1 nap a day, somewhere between 3 and 4 being let go of. And then at the bottom, you see what we typically call our sleep cycles. And we all have sleep cycles. The cycles are a little bit different depending on your age. But basically, they involve stage 1, 2, and 3 sleep, which is what we call non-REM or non-dreaming sleep. And then our REM sleep, which I've marked down at the bottoms there. And our cycles on average, but they change during the night as well as with age, are somewhere around an hour and a half between each cycle. And at the top of each of those, as we drift back into our lighter sleep, we can have an arousal. Sometimes we're aware of those arousals. We kind of wake up easily because we hear a little noise somewhere. Sometimes we're not at all aware of those arousals, and we just turn over in bed and grab our pillow and go back to sleep. But arousals are normal. It's what we do with arousals and how we manage arousals and when they occur. That's what we really need to look at. Specifically related to kids with neurodevelopmental disabilities, and I'm going to say NDDs just to represent that for the rest of of my slides. They're super common, and actually, while the range I've put there is 34 to 86%, most studies recently are really talking about sleep disorders in the group of children upwards of 70 and close to 90% of the time. So it's common to the point of almost ubiquitous. They're often much more complex. They're partly physiologic, they're partly behavioral, and they are just much more frequent. But families bring them to the attention of their healthcare providers or their therapists very seldom, less than 15%. Recently, this is improving a bit, but it's still pretty uncommon that this is the primary reason to come unless it's quite significant. In kids with NDDs, we see all different kinds of sleep problems, but the most common ones are the most common ones that we see in everybody. Difficulty settling, night wakenings, and early wakenings. But we also get things like parasomnias, the walking in your sleep, talking in your sleep, bruxism, those types of behaviors. You see atypical behaviors like rocking or head banging, and you also see that the daily rhythm, the circadian rhythm, can be off. And so we see all of the neurodevelopmental sequelae in kids with NDDs, just like we do in contributorial. There are physical factors, behavioral challenges, also impairments with in the text, because that's both important for understanding what the sleep problems are as well as treating them. So I'm going to review a few of the NDDs. I won't obviously be able to review all of them, but I want to pull out a few things here just with all of them. So it's going to be very much just a touch for each, and then I can go into more detail on any of them or others if you'd like at another time. So sleep disorders in autism is super common. The research measures it somewhere between 60 and 80%, and it's often in younger children where you see them starting, but they'll persist into adolescence. There's a lot less research as you get into adulthood, but it wouldn't at all surprise me if it persisted into adulthood. I used to be able to say there was lesser known, to use older language, about Asperger's syndrome compared to the autism spectrum, and it used to be thought that kids with Asperger's didn't have the same amount of sleep difficulties. But in fact, recent literature is saying, yeah, they do. It may be different in some ways, but yes, they do. And you can see the most common concerns on this slide are quite variable. They can be shorter sleepers. They can have much longer wakenings in the middle of the night, and sometimes it's like it's daylight. They're awake, they're ready to play and do stuff. They're not at all appearing tired, or they're awake in the middle of the night and going through a routine or some repetitive behaviors that they're engaging in. They're also early morning awakeners, and they may have a variety of parasomnias, but it can be difficult to tease apart what's a parasomnia and what's a repetitive behavior. There are a bunch of theories that are being explored in terms of why kids with autism may have difficulty sleeping. The theories include things like that their melatonin production is actually reduced, or it may be that the melatonin secretion at night, because we all secrete melatonin when it's dark and we suppress it when it's daytime, when it's light, there may be a delay in the secretion of melatonin for kids with autism. It's also been speculated that it may be a primary arousal deficit, so they may arouse more easily to some things and less easily to other things. There's certainly the impact of anxiety. Others have suggested that there's an impact of primary gastrointestinal problems. And there's a body of literature saying that their architecture itself, so by architecture what I mean is that sleep cycle that I showed you earlier, the patterns of REM and non-REM sleep and what that looks like, that their architecture may be different. They may have less REM, they may go into REM much quicker, but it may be more infrequent throughout the night. And then sleep spindles, I'm not going to spend any time on, but they're really something that we see on the EEGs, and they're our first indicator that you're falling asleep, moving from sort of conscious napping to actually sleeping. And they may not show as many of that, so actually their sleep depth may be different. And sometimes this is seen as, all of these problems are seen as intrinsic to autism. It may be, it may not be, it may be more complex than that. We still most commonly treat sleep disorders in autism, as we will, as you'll see with most of them, focusing on excellent sleep hygiene, and I'm going to define what I mean by that in later slides, and adding in some melatonin. I'll also talk briefly about melatonin later as well, but the other things that we have to consider are really management of the sensory patterns during the day as well as at night, how they may contribute to anxiety and repetitive behaviors. Kids with autism, as you know, need to have an excellent sleep routine as well as an excellent daytime routine, because if they don't have that, it's often disrupting for them. And we have to think about the sleep associations, those things that we need to help us fall asleep, which for most of us we often don't think about as much. They may be our pillow or our own bed, but for kids with autism it can be unusual things or unusual patterns or routines, and then we'll consider some melatonin in them. Just to very briefly talk about a number of genetic disorders, because they all have some slight differences. Kids with Down syndrome, the first thing that always needs to be ruled out in kids with Down syndrome is an obstructive sleep pattern. Now, I'm not a respirologist, so I'm not going to focus lots on obstructive sleep apnea, because that's really for the ENT docs and the respirologists to manage. But it's often missed because people may not appreciate the multiple factors that contribute to obstructive sleep apnea in kids with Down syndrome. So I've listed a bunch of them there, and you can see that they're really all anatomic differences. They relate to the tone of the upper airway. They relate to what the impact of that tone is in terms of where the tongue is held. But it can also be other things that are metabolic, like hypothyroidism. And because of any of those things. Kids with Down syndrome may have trouble falling asleep. It's common, and they can have very fragmented sleep. But the difficulties may not just be obstructive. We look for those. They need to have that ruled out before we look at anything else. But they may also have central sleep apnea. And by what I mean by central sleep apnea is the part of the pausing in your breathing that is neurologically controlled. So they may just pause in their breathing as well because of central control, not just because of obstructive issues. Their architecture can be atypical again, less REM sleep and more wake after sleep onset. That's what the WASO stands for. So they're more wakeful, and they may have more periodic movements, but you would see that on a polysomnogram if you did this with these kids, and these kids often need a polysomnogram. So the first step in managing kids with the sleep problems in kids with Down syndrome is know whether they have obstructive sleep apnea, test it, look at periodic late movements, look at central sleep, and then and only then really look at the excellent sleep hygiene. You can institute good plans for sleep hygiene before or during while these things are looked at, but often it's really difficult to tease apart and manage it fully until you've managed the obstructive part. The other thing to consider in kids with Down syndrome, and this is appreciate a very brief overview here because there's nocturnal seizures, and nocturnal seizures are this is a microdeletion syndrome where there's a deletion of part of chromosome 17, and the kids with Smith-Magenis, it's a rare syndrome, but I'm talking about it because they have a unique problem with their sleep. They have part of their phenotype is to have severe behavioral difficulties, often with hyperactivity and aggression during the day. But what their chromosomal deletion causes is a reversal in the melatonin during the day. And there's been only like 3 studies out there, and they're very small n's, very small numbers of kids involved in them. And the studies have suggested, they're all Swiss studies from the same group, and they've suggested using a very specific medication, which is a beta blocker, and a particular one during the day to try and suppress melatonin. But you can appreciate that, and even I appreciate that most docs don't want to put a young kid on a beta blocker who doesn't otherwise need a beta blocker. So we tend not to use the ace-butylol during the day because there's really very limited evidence, but we really don't have anything else that works during the day. So these guys go to school, they fall asleep in the middle of the day, they get irritable and cranky when teachers try to wake them up, and they don't want to do anything. And then even if you give them huge doses of melatonin, they're not that sleepy at night. So we do excellent sleep hygiene. I've had a couple of families who have kids with this disorder, and they do their best. And this is one where you do not look at the books out there, any of them, because this is off the books. We have to do some very specific behavioral management. Prader-Willi is another syndrome. This is another microdeletion 15. Chromosome 15, and they have a different pattern. They have a hypoventilation, obstructive sleep apnea, kind of upper airway resistance pattern. They have lots of daytime sleepiness, but these guys may also be at risk for narcolepsy when they're older. So this is another unusual one. So narcolepsy, as they get kind of to be into their teenage years, you have to look at both obstructive sleep patterns in these guys, because the kids with Prader-Willi syndrome, these are the guys who like to eat. They have low tone. They often get much heavier as they get older. So you have to look at that obstructive part, but if they're falling asleep during the day and they're older and they're teenagers, you have to think about narcolepsy, and it's a completely different treatment. Very briefly, for some other genetic disorders, Fragile X, common problems, difficulty settling, because these guys with Fragile X often have kind of ADHD, mildly autistic kind of phenotype, lots of night wakenings, short sleep duration, but they can also have obstructive sleep patterns, so you can't miss that. The questions we ask when we see guys with obstructive patterns is, do they snore? Is their snoring loud? Are they pausing after they're snoring? Are they having that kind of gasping pattern after their pause? That's why we ask those questions. Kids with Williams syndrome, they have a higher incidence of periodic leg movements. So these are restless kids at night, and it's not just restlessness with sleep associations, but their sleep associations come secondary to that because parents are trying to manage the restlessness at night. Kids with achondroplasia have both obstructive sleep apnea and central sleep apnea. Kids with Rett syndrome have very atypical cycles, and they can have lots of nocturnal events that include seizures, but also can include behaviors like screaming and laughing. So the atypical behaviors. Kids with Angelman syndrome, sleep-wake cycle abnormalities, they can have lots of bruxism, lots of grinding of their teeth. They can also have nocturnal laughing. They can have some walking in their sleep. And in fact, kids with Angelman syndrome can also have difficult, there's many about the regular sleep. We need to do excellent behavioral management and safety. I'm going to very briefly talk about cerebral palsy because they also have a combination of difficulties. Cerebral palsy, as you know, is a static encephalopathy, which means it's not in and of itself, the reason for it isn't changing with time, but there are multiple things that occur in kids with CP, and again, there's a range of different sense problems, cognition problems, communication difficulties, perception, behavior, and they can have concurrent epilepsy, just like many of the other NDDs. They can have primary sleep disturbances, so primary to CP itself with various sleep-wake cycle problems, parasomnias, and obstructive sleep apnea. But the spasticity itself that's inherent in CP that defines CP often, not always, can cause a lot of difficulties in terms of the movement difficulties in the middle of sleep, the difficulties in turning over if you have more generalized spasticity, the pain that can be associated with spasticity, the effects of epilepsy and the side effects of managing epilepsy in terms of the anti-epileptic medications. They can have nutritional deficiencies that also contribute, iron deficiencies, calcium deficiencies, and other medications that they may be on can also contribute to their sleep difficulties. This is a really difficult one, and it's variable because the presentation of CP is highly variable. So it really needs to be individualized, and it can be complex. Parents also will manage, I didn't even talk about things like their G-tubes that they may have, and how do you manage that in the middle of the night in their feeds. You really have to go system by system in kids with CP, and you can't generalize management from one kid to another because it's very individualized. There's been studies on kids with CP, and I think these numbers in this particular study vastly underestimate the difficulties that parents experience. They can also have abnormal EEG patterns. And so what I mean there is that they're primary neurological patterns that can impact sleep in terms of their sleep architecture, in terms of even what those sleep spindles look like, and their wakefulness. Very, very difficult. FASD, it's another complex disorder where there's also a significant kind of environmental impact on the sleep difficulties. So again, a variety of risk factors for sleeplessness, and it's really important to look at sleep in family context in kids with FASD. Alcohol can primarily affect the brain as well as the neurotransmitters, and so the kids can have primary sleep problems, but they can also have primary behavioral problems, primary cognitive problems, and they can be living in often very variable environments. There can be very stressful environments that they experience. They may have histories of malnutrition or stress that really contributes to their poor sleep. And it's really important to think that maternal prenatal mood disorders may also predict poor sleep in toddlers with FASD as well. It can be complicated by disrupted attachment. There's lots of interesting literature on sleep disruption in kids with FASD in care, as well as sleep disruption in kids who are in care whether or not they have FASD. And all of these things can really impact how we try to manage sleep hygiene. They can also have lots of sensory processing difficulties. And, you know, it's really interesting to me. I put this slide up because lots of the medical profession see sensory processing difficulties as a behavior and not as a neurologically oriented and controlled experience. And so I just put some of these details here to remind people that the sensory processing that you see and you measure, particularly if you're OTs, has a neurologic basis, and we can relate behavior to that neurologic basis. It's not, quote unquote, just a behavior. It can also be related to sleep anxiety and how we respond to stress and how we are aroused. So all of those things are really part of what we have to assess when we're looking at kids with FASD. And so again, treatment principles are very holistic. So I'm going to move a little bit into some of the treatment considerations. And as you can appreciate, I think by now, we really have to treat comprehensively and assess comprehensively. And there's no single one starting place. There are a few basic principles here, but for all of these kids, the sleep hygiene and treatments need to be individualized because parents and children are ready to start in different places, and there may be medical considerations that drive where we start. The goal for any of this is to reduce the burden of care, and so we may have to try multiple things at the same time. And when we're treating behavioral parts, one really has to be cautious about kids who have histories of trauma, kids who are in and out of hospital, and kids who may be newly adopted or multiple foster placements, because the tendency to go to the books or to go to the internet kind of basic sleep recommendations do not always work and sometimes are in fact harmful for those kids. So we really need to consider how and when we apply different principles. So this is a model that I've just kind of adapted. Dr. Jan is a neurologist who's since retired out in BC, and I've added a few things to his model, but it's just a different way of thinking about all of the things that we need to consider when we're treating sleep, and how the things we need to consider when we're also not just treating sleep problems, but promoting good sleep health. So again, the stepwise approach, number one, is to make sure there isn't any obstructive sleep, because really you can't do very much until you know whether obstructive sleep apnea is there, and if it is there, you just need to be referred to the pediatric sleep program for a polysomnogram. It's really important to understand that child's environment thoroughly, not just their home environment or their bedroom environment, but their preschool, their school, other environments they may be moving to, living in, experiencing in all different ways, because consistency is really key, and those differences can really inform what you do. And you have to understand the child's reactions to those different environments, as well as the constraints on parents when they're trying to institute a recommendation. When something isn't working, before you consider it isn't working, ask what the barriers are to it working. Ask why it isn't working, because sometimes there's some really good reasons why. Sleep hygiene has biological basis for why we say what we say. And in general, less is more. Rooms need to be quiet, comfortable, consistent, and familiar, because we're trying to reduce arousal. And if we're talking about children who may already have a tendency to be more aroused for a whole variety of reasons, then it's even more important to have a calming, quiet, consistent environment with lots of predictability. The bedtime environment should be dark and cool. Dark because that's how we release our melatonin. Cool because that supports the release of cortisol early in the morning, which is why if you ever wake up at 4 in the morning and you feel particularly cold, it's not just because you turn down your thermostat at night, it's because of what your cortisol is doing in the middle of the night. So keep your bedtime environment cool. Keep the bed itself comfortably warm. The emotional environment should be secure and calm and positive and very calming. And I see lots of kids who have understandably frustrated parents or kids with lots of behavior difficulties that are challenging people's ability to be calming, but it's really difficult to fall asleep when this isn't there. There are behaviors that are incompatible with sleep. Screens are incompatible with sleep in any form. Use the bedroom that is used as a punishment space. It's not compatible with a calming space that you need, the emotional environment that you need. Whoops. Hang on. The daytime schedule is really important. Kids who experience lots of changes in their daytime schedule have a difficult time regulating themselves back to a nighttime schedule, again, because the daytime schedule impacts your routine. Kids need exercise, and kids with neurodevelopmental disabilities often get way less exercise, not a little less exercise, but way less exercise than most kids. And they need good exercise. They need good exercise partly to drive their sleep drive at night. They need good exercise to help regulate them metabolically. And I mean, for any kid, doesn't matter what their motor disability may be, but no matter what it is, they should get their exercise in the morning and in the afternoon and not when everybody comes home at night, because that's a really difficult time to upregulate people through exercise and expect them to downregulate to sleep. We need good exposure to natural light, not screen light, not indoor light, natural light, the full range of lux that you get. The lux you get outside by the sun is at least 4 to 5 times higher than the lux you'll get with your best full spectrum bulb indoors. Kids need to get outside. And lots of kids with neurodevelopmental disabilities of different kinds spend a lot of time indoors. And then, of course, a review of medications. Behavioral management. So these are basic principles that you really consider no matter who the child is or what their difficulties may or may not be. But the reason I put them here to remind us is that a lot of the times it can be difficult to institute some of these behavioral management principles with kids whose medical routines or need for hospitalizations or different illnesses challenge the types of things that parents have to do in their day-to-day care of the child. Think of things like feeding, think of things like being with the children, think of things like monitoring for epilepsy. Those become associations that kids have that they need to fall asleep with. So do they need to fall asleep with parental presence because the parent is understandably managing their feed at night, or because the parent is watching for their epilepsy, or needing to turn them because they can't turn themselves? It's still a behavioral principle that we have to go through. And while the slide makes it look easy, it's actually not very easy to manage. And this is where you do some priority setting with the parents and say, what are things we can, first of all, be intentional about? Let's recognize these things as sleep associations. And what are the things that are modifiable? And what are the things that are unlikely to be modifiable? So let's talk through those things, because I can believe that is super frustrating for people. Don't be present when your child is falling asleep. Let them fall asleep on their own, when in fact that's completely unrealistic from a care point of view. It's also really important to address the sleep hygiene of parents themselves, because parents who are managing tons of care during the day are parents who may not have the best sleep hygiene themselves for very understandable reasons. They're tired. They have a lot on their plate, and they may be stressed physically and emotionally themselves, and their sleep patterns are linked to their child's sleep patterns. Partly sometimes in a way that we can talk about. So parents will say, you know what, I did this, I know I'm not supposed to, but I was just so tired, my child was just so tired, we did this out of self-preservation. But sometimes it's not quite so obvious. And so the parent's sleep hygiene should be managed so that you have a parent who's ready to help manage the sleep hygiene of their child. And again, the goal here is to reduce burden of care and needing to address multiple areas at once. Here again, we start with where a parent is ready to start. Even if it isn't necessarily where you think the best area is to start, we start where parents are ready to start. So I'm going to go way back. If you can remember my first child, who I didn't identify which his particular disability is, because it could have been a lot of different ones. Really what you need is a team. When I say a team here, I don't mean a specific sleep team. Any of you guys who are part of the care team of any child with a neurodevelopmental disability can be part of that child's sleep team, because you'll all have your areas of expertise that you can apply in your particular specialty to help a family manage. But it's important to talk about it. And sometimes you guys may ask about sleep much better than the docs ask, or a family may tell you about sleep problems much better than they'll tell their doc, who may have a very busy clinic and just doesn't think about asking it. So you can bring it also forward and say, write a note and say, hey, this kid is really struggling with their sleep, and we've done this, that, and the other thing, and they need another look at this. For Jordan, we really needed to look at what are the biological things that may be contributing to his sleep, what are the environmental things, what are the sensory considerations, difficulties, and I'm not going to go through those in detail because he could be a whole session all by himself. For the OTs in the group, you'll know a lot of these different areas, but I've pulled them out before when I've talked in other situations, because I think it's really important to think that a lot of these areas that we can separate out how we think about sensory, and these are by no means comprehensive, can be applied in various ways to sleep. I'm happy with kids who want to sleep in a little nested space in their room, as long as that's safe for them. It should be dark. Some kids may like a nice deep pressure before they go to bed. Other kids won't like that. Some kids like to be rocked. That can be really good, but it can also be a sleep association that's really challenging to manage. Different scents can help, can be nice and calming. Different tactile things, but don't always assume the tactile things. You know, before I did this, I would always assume tactile things might be soft and calming and smooth. The guy who liked to fall asleep with his hard metal square piggy bank, and it was like a robot, a little robot, and it had sharp corners and it was cold. And I thought, why would you want to sleep with that? But his mom said that's what he slept with, and if he didn't have it, he didn't fall asleep. So I was like, okay, whatever. So sometimes white noise helps, sometimes it doesn't. You guys can all imagine a whole bunch of stuff about these strategies related to sleep, as I would like to see, because they're really useful strategies. Melatonin, again, this could be a whole session. The theory is that for some kids, their sleep cycle is off because of either difficulties with secretion or suppression of melatonin. It's important to remember that melatonin has multiple effects, not just sleep. It has metabolic effects on other things like immune function, for example. It has a circadian rhythm regulatory effect, and we take advantage of its sedative effect in sleep. So we use its circadian rhythm regulatory effect when adults use it for jet lag, for example. It works for some kids, it doesn't work for others, and it has to be used properly. And I've just given you a very simple dose range here. You may have kids where the dose is pushed much higher than this, particularly in kids with neurodevelopmental disabilities. And you may have kids where it's said it doesn't work, and sometimes that's true and sometimes that's not. While it is probably the safest thing we have out there for young children, we still don't 100% know that anything is safe, so let's be cautious. Let's be cautious in its use. There are other things like light therapy and chronotherapy, and I think I'm not going to spend a lot of time here other than to let you know the best light is during the day, brightest in the morning, getting dimmer towards the end of the day, and daylight. Get outside. So the final slide or two that I have here, this is a study that was done by Penny Corkum and Shelley Weiss. I'm participating in the second phase of their study. The original phase of their study was, it's an online kind of cognitive behavioral therapy thing that parents could sign up for and learn some principles of managing sleep. And it was actually quite good. And they released it at first for kids, typically developing kids. They're now revamping it specifically to address the needs of kids with different neurodevelopmental disabilities. And it's gone through a whole bunch of work, and it's probably going to be released sometime this spring, possibly as late as the fall. So I think it's going to be interesting. So maybe this is just for you to kind of keep an eye out, because they'll be looking to recruit families. And the nice part of this is it's an internet module, so you can do it at your own pace and at your own time. So just keep an ear out. When I have more information, I'll let you know more information about it. So just some final things is to really consider the complexity of sleep difficulties in kids with neurodevelopmental disabilities, that it's different for all of the kids. There's no one size fits all here, that you have to think about environment, biology, sensory, and you really have to manage a whole bunch of different things in a very team-ways approach, and that there can be different and specific patterns for kids with specific problems, but there are also overlapping patterns that we can consider in all of the kids. And I think I will stop there. Oh, this is just something that some people use, a little acronym BEARS, to help probably more docs than therapists remember to ask about sleep, but it's not something I made up. This is something that's out there and quite widely available. So you can think about this if you like. And then I think I'll stop there and open for questions.
So if anyone has any questions, either we'll bring you the microphone, or Anna can just repeat the question so that people from the webinar.
I don't think I meant to escape that off, but I did. Okay.
As outreach therapists, we have a lot of parents that ask us about weighted items. Even though we know as therapists these are not recommended, it seems like the internet is delightful and nothing ever dies on it. So they still keep finding.
I know.
Recipes for weighted blankets and things like that.
I know. And oh yeah, sorry. So the question was about the use of weighted blankets. They're used pretty commonly. Therapists have families asking about these all the time, and that there's all kinds of different recipes for how to make the weighted blankets. I appreciate the question because I get asked that a lot. I don't recommend them, as you know. Sometimes what families, it's kind of important to understand what families are trying to address through the use of a weighted blanket or vest or whatever. And often it's not all that clear when you really ask them, like, what are you trying to help with that? The vest, sometimes it's easier because usually it's something about the child's hyperactivity and they're running around and they think that'll kind of weigh them down. But at night it's a lot less clear, and maybe you can appreciate that, you know, if there are kids who have obstructive problems, you're actually in really serious difficulties if you're using weighted anythings, and you may not always know that. So it's not just considering the heavier kid, but considering the kid who may have hypotonia really should not have a weighted vest or a weighted blanket. But sometimes if we talk with families a little more, maybe what they're talking about is they're trying to do something to reduce arousal in the child. And so if rather than saying just don't use the weighted vest, which we do need to say, if we say, well, let's talk about arousal and ways to manage arousal, that sometimes can work. And I find that my appreciation for the basic things like fresh air and exercise in any form is grown incredibly and appreciated often because of the busyness of things that we do day to day. The care of kids with different disabilities can be very complicated. It's hard for parents to get exercise and fresh air. It's hard for their kids to get exercise and fresh air, especially if they have a lot of physical contractions around them. But getting some movement helps reduce arousal. Getting some way of burning some of that energy. I try different different language with families, and then thinking about the evening time, prolonged period to really spend calming time in whatever way you can. And it may sound broad for me to say it's kind of families like to look like in the day, getting exercise during the day itself, what can be calming at night. It's a nitty-gritty, and then that kind of discussion, I can get them away from weighted vests.
Are there any other questions?
Thank you very much.
Thank you so much to Anna for coming to present, and for everyone here in the room who came, and for everyone on our webinar. So if you want to watch the recording, go to our website, sscy.ca, and then it's in the About SCY section, and you can view the recording of this webinar and share it with everyone else. So hopefully everyone comes back next month, the second Tuesday of the month. We'll be learning about a research project that's happening here at SSCY Centre to develop a new type of clinic for treating children with plagioccephaly. And then in April, Matt from the Mechanical Design and Services Department will be telling us about the department and how you can apply and what you can get from the department. So if anyone has any questions, you can about the sessions in general, you can contact me. My name is Jessie, and my email is jshea@rccinc.ca. Thank you very much for coming.
Yeah.